female plastic surgeon.
Yes,
That is a traditionally male dominated.
it is.
So, do women prefer to have a female plastic surgeon or a male, and in what cases?
I have such a nuanced view on this because the way that I got into plastic surgery is because I was a patient first and I had a male plastic surgeon. And he actually compelled me to go into plastic surgery because my relationship with him was so unique and incredible. And he was such a phenomenal human being and surgeon. And he changed my life. And so I have I do believe that I have something to offer women because I do think that I can meet them on a level and understand what they want and how they feel about their bodies because I am a woman. But then I was also impacted so greatly by a man that it's such a hard question for me to answer because do I think that my surgeon was any less because he was a man? And did he meet my needs any differently? No. But I've seen a lot of instances where I think there is some communication lost between male plastic surgeons and their patients.
So it's more about the particular approach of that individual.
I think so.
Their personality, their connection.
Yes.
So, were you already in medical school? Were you already doing a residency?
No, I was younger. I was still in college, even pre-college. And I actually had several surgeries over a course of a few years. And then I actually kind of had a whole different life before I decided to go back to medical school. I did college. I did a master's in public health.
Oh, wonderful.
I worked in research and substance abuse for 5 years.
Wow.
I contracted with the CDC for a little bit during that time with their alcohol division.
Where were you? What part of the country?
Atlanta.
In Atlanta.
Right by the CDC.
By the CDC. So that was a natural fit.
Exactly.
Is that where you're from originally?
Yes.
Yeah. So that is an incredible trajectory. And, public health, the CDC, I mean, their mission is worldwide, obviously impacts the entire world, as we noted recently. And so that propelled you to go to medical school?
It did. To be honest with you, I only went to medical school to become a plastic surgeon. But I do have this other half of me. And I mean, it goes together. It complements each other. But I have a really big passion for health and for public health. And for, fitness, lifestyle choices that contribute to your overall health. And I think the public health part of me, I needed to do that. And that fulfilled this. I wanted to have a global understanding of why some communities are healthy and some are not. Right. But then I've always wanted to work with my hands. I didn't like sitting at a research desk. I didn't like, just working with numbers.
Right. So
doing research.
You wanted a balance. So the surgical aspect and helping people improve their lives, but at the same time, you have not only theoretical knowledge, but also how to apply that to communities that have a high level of the social determinants of poor health.
Right.
Correct?
Right.
We're on the same page.
Absolutely.
So the way I was introduced to her was by your cousin, Danielle, a Wyatt mutual friend, who, as we all know, she's into total fitness and health and plant-based diet, and said Lindsey is of the same opinion, and that's what she follows. So that was a great connection because obviously that is important not only as a doctor, but also in influencing your patients to beyond what the scope of the surgery is.
Right. Be an example by doing.
Yes.
I think, if I practice what I preach, then when I'm counseling my patients, that the only way to get through a surgery with the minimal risk and the best outcome is to also work on yourself. There's only so much that I can do physically with your body.
Right.
And there's so much optimization of a surgical outcome and also minimization of risk during the surgical process that is done by the food that you take in, the water that you take in, what you surround yourself with, where your food is coming from. And
absolutely.
Has that always been a passion of yours?
I think so.
Or did you,
evolve
working for
into
the
it?
CDC, did you look at stuff and say, wow, look what's going on?
Well, I think public health really opened my eyes because when I was taking those public health classes, getting my master's, we started looking at the charts of the obesity trends
Yes.
in America. And it was kind of at a pivotal time where it started really skyrocketing.
Yes.
And then also obesity in children. And that really struck me because I was thinking something is really wrong with our culture if our children are obese.
No doubt. And seeing type 2 diabetes already in
Right.
children or young teens, right?
I have a genetic propensity for type 2 diabetes. And so, I was always thin as a child and my mother always cooked. So I think naturally, even though my family didn't really have a concept of calories, my parents' generation and just the lineage that my parents came from, they didn't ever, I don't ever recall my parents saying the word calorie, to be honest with you. They didn't teach us about nutrition.
Right.
But naturally, because my mom cooked at home every day, I think we were pretty balanced
Sure.
in what we ate. But I remember the first time I ever had issues with my weight, I was like 19 years old and Starbucks became a thing.
Right.
And I worked at this hair salon as the receptionist, and they would send me out for Starbucks every day. And I had no idea what calories would do to my body.
The
and I would order
frappuccinos and so-
frappuccinos, the Java chip frappuccino.
Yes.
I
Loaded.
ordered that.
Dessert for coffee.
Yes.
Yes.
But I didn't know better at the
600
time.
calories,
Yes.
40, 50 grams of sugar.
I had no idea. And
Yeah.
over the period of a month, the first month that I started ordering at Starbucks, I probably gained 8 to 10 pounds.
Wow.
And it was a massive wake up
Were
call
you
for me.
exercising at the time?
No, I wasn't.
Okay.
Did you know it was the Starbucks? Because that was the only.
It was the only new thing. And our hair salon was next door to Johnny's Pizza.
Ah.
And the pizza boys I was friends with. And they would supply, I didn't eat the pizza, but they supplied me with free soda.
Wow.
Oh,
And so
wow.
I was drinking, I
All day
can't even,
long.
I mean, I have not touched a soda or a drink with calories in it, except for an occasional cocktail. But I made a decision many years ago that I would never drink anything that had any additives in it. And so
Right.
I drink water and I drink coffee with no cream, no sugar.
Just
And
black coffee,
That's
basically.
what I drink
Yeah.
throughout the week.
And so those lessons that you learned, and that was a great experience at 19, really allowed you to see the impact of all those poor choices that
Mhm.
a lot of young people are seeing, especially as they go on their own, right? In college, a lot of young people gain those 10, 15
Right.
pounds quickly.
Well, you're on the perfect spot. So, hey, welcome everybody. This is the Leverage Podcast. I'm your host, Davio Venturis. I'm joined, as always, by the esteemed cardiologist, Dr. Federico Macy. Most of you know him as Dr. Suave. We are joined by the cardiologist, Lindsey. Now, please help
No.
me pronounce it.
Plastic surgeon,
Yeah.
not cardiologist.
Oh, that's right. Plastic surgeon. Even
Yes.
better. Oh, finally, we get another voice. The plastic surgeon, Lindsey
Tavakolian.
Tavakolian.
Yes.
That's what's the history of that last name?
It's my married name. My maiden name is Cochran, Scotch Irish. My married name is Iranian.
Right.
Oh, very cool.
My husband is Iranian.
Right.
His parents were immigrants.
Persian.
Yes,
A long time
Persian.
ago.
That's a culture
Yes.
older than the
Yes.
Greeks.
Yeah, a little bit older.
Yeah.
Yeah.
Mhm.
They used to fight a lot, right? Back then.
I think they fight over who actually started history. Really, they claim a lot of.
Yes,
Well,
there is
they
that.
have an older history, but we actually were the first historians that were not like mythological stories, but actual what actually happened. Even though it was all propaganda, but
Yes.
that's what they say.
We just came back from Greece,
Did you really? Where'd you go?
Santorini.
Oh, of
Very
course.
nice.
Mhm.
Yes.
My family's from Corfu, the other side of
Okay.
the Ionian Sea.
Yes.
If you ever want to go back, let me know. It's worth going.
Absolutely.
So, the Leverage Podcast, it's all about trying to leverage health
Mhm.
and help people get information because you guys know this stuff, but most people
Right.
they don't know the difference. Oh, what's the harm in a little Starbucks?
Mhm.
So that's kind of what our mission is. So it's great to hear that you're not only helping people with the plastic surgery side, but you're also trying to educate them
Yes.
to
To
be good from the inside
Improve
out.
their lifestyle.
You know
Right?
what is interesting? I was having a conversation with my husband yesterday. So he's an orthopedic hand surgeon. And he had a gentleman come to his clinic who had a hand problem. He needed hand surgery. And my husband gave him options. And he said, however, you're diabetic, your A1C is over 10, you're not a candidate, you have to get this controlled. And over the next 20 minutes, he realized like he needed to have a bit of a conversation with this man about the impact of diabetes on his health. So here's this orthopedic hand surgeon having an in-depth conversation about diabetes with his patient. And at the end of it, his patient said, I have never had a doctor in my entire life spend this much time educating me about the impact of diabetes on my health.
Yes. So that speaks volumes about your husband for sure, but it does not speak much about the prior, and I'm assuming this person has gone to various physicians,
He has a
primary care and so on.
good primary care physician.
Yeah, well, not good enough, because A1C has to be at the top of the list. Lifestyle, obviously diet, exercise, decreasing stress, avoiding certain behaviors like substance abuse disorders and so on that contribute to that. So not good enough if you're walking around with 10.1.
Nutrition isn't something that they teach you guys, right?
Look what I got here. I'm going to check my sugar right now while we are speaking. I've got a cool new technology that measures all kinds of vital signs, including blood pressure, heart rate, and blood sugar.
Tell me more.
As we speak. Start. So I've got it on because I think most people ought to have one of these. And this was not expensive. It cost $49.
Really?
Yes. So I'm going to measure my blood
incredible.
pressure in a second. And this is still in millimoles, which, obviously in England, Canada, millimoles per liter is a measurement.
Is this the Canadian company that you've been working with?
Another one, but that one too, that predicts your sugar. So mine is 605 millimoles. So the conversion factor to milligrams is 18. So if I multiply 6.05 times 18, it gives me in milligrams. So 108.9.
Are you fasted or?
I fasted, but I had coffee with
Seeds.
with almond milk in it. So that's probably reflecting that I had a big coffee. So because I should be closer to 100, but it's pretty good.
That is good.
Do you
Not
do
bad.
intermittent fasting?
I've never strictly done it. I think as a surgeon, I naturally do intermittent fasting.
Yeah.
I've spent the greater part of my
By force.
Yes. I think I've spent the greater part of my training. So my plastic surgery training was 6 years. And I spent a lot of that in the operating room, not breaking scrub, not going to the bathroom, not eating, not drinking, fasting, essentially.
Right.
I also, in order, you have to find ways. The advice that I have for my patients is you have to find ways to make health and a healthy lifestyle fit for you in your circumstances. And for me, my big fear was that during either medical school or residency, I would lose that capacity to be healthy. And so I always
Why?
Because you're working 100 hours a week.
Yeah, you're working.
It's unhealthy lifestyle.
I would go in for work at 5 a.m. on one day and not go home until 6, 7, 8 p.m. the following day because I would take call overnight.
38 hours later.
Or more. 30,
So,
plus.
cardiology is very similar. As you know, we're married to the ER. We're married to the ICU, the coronary care unit, post-op. So there are a lot of parallels, and we do beat up ourselves when we're young, and maybe we're in our 20s or early 30s doing that. And it is not healthy mentally or physically.
They're reducing that now, right? Because they realize it causes all kinds of errors, and it just...
By the way, there's my blood pressure. I just took it.
80-hour work week.
122.81.
Oh, perfect.
Okay, so I recommend these new technologies for people.
I love that. I'll have to get the information.
And it
about
has
that.
Bluetooth. You can send it to your phone, and from there to your doctor's office.
That's incredible.
$49.
I think that's the future of healthcare.
Self-monitoring.
Yes.
When you do that, you're less likely to misbehave. You're getting immediate gratification and not pricking your finger.
Absolutely.
Or having something stuck into your skin like some of the other ambulatory glucose monitors.
Well, if you had known when you drank the Starbucks what it was doing to you, you would
have done it.
Right, exactly.
I wouldn't have done it.
You would have gone, oh, that's it. Throw it out.
I can't even imagine what my blood sugar was after drinking those.
But back to the stress. So it is very common for interns, residents, and of course, third, fourth year medical students to go on a, not voluntarily, but involuntarily by the fact that they're doing all the training to eat poorly.
Right.
And hospital food traditionally has not been the best.
No.
And then you have
Sadly.
the pick-me-ups, which means extra coffee and or extra sodas and a cookie here or there, because you're in her case, you're in the OR for a 3-hour case. I haven't had dinner. It's already 9 p.m. I'm not getting out. Okay, grab a cookie on the way in for a little sugar or a banana.
The doctors' lounges, the surgeons'
Yes.
lounges, they're all processed food like Nutter Butters.
Yes. Yeah. Saturated fats.
That's a
and
big problem.
sugar.
Is that something you've tried to get them? Oh, go ahead.
But what I was going to say is that I actually made the decision because for me, I'm kind of all or nothing. If I allow myself a little bit of slide, then I don't make good decisions. And so
That's your gut bacteria calling.
yeah.
The good gut bacteria.
No, or the bad.
Or the bad
Yeah.
saying,
Yeah.
feed me the Nutter Butter.
Yeah.
But I made a decision at the beginning of residency that I wouldn't eat on a call shift overnight past the time of dinner. And so even if I was up working all night in the ERs, I didn't allow myself to touch food. I could only have something with no calories, so water. And
Right.
I don't believe in like diet things either, like
So
no
that's
sugar.
that's a lot of self-discipline, right? We see tremendous obesity, unfortunately, among nurses in hospitals, especially
sad.
those that work the night shift.
Yes.
And you've seen it, right?
Yes.
It is horrific.
Well, in the not just the call rooms, but like the rooms where the nurses have their breaks. Every time I walk by one of them, it's just stacked with like donuts, pizza,
Yeah.
comfort food. And I think
Yes.
it's because you're working in a stressful environment caring for other people and you want to grab something that makes you feel comforted.
Yes.
And I think naturally these foods that have like this really high,
Dopamine
like
release quickly,
dopamine
endorphins
response,
and dopamine. Yeah.
it makes them feel better.
Yes, that's true. She walked in with her coffee cup today. Can we see what's on it? Roderick, can you point to that a little bit in a second? I don't know if it's clear
it.
on that
It's
screen,
a
but
little shiny.
Plastic surgery is psychiatry that works.
It is.
there you go.
A mentor of mine gave me this
That's kinda
when I
cool.
graduated from residency.
Yes, very cool.
So you said that what inspired you to become a plastic surgeon was you had some plastic surgery?
Yes, I did.
Do you mind me asking sort of what that was?
Yeah, absolutely. I had breast surgery. I was younger and it wasn't for purely cosmetic reasons. I had some asymmetry and it was enough that I thought it should be addressed. And it was really important for my self-esteem
Yeah.
and my ability to, engage with my peers and not have to think about it. And in my mind, that's one of the best lanes for plastic surgery is not to pursue this, Instagram fake airbrushed ideal of a human being, but to take things that are a departure from normal and a departure from like the average sum of how the average human being appears.
Right.
Something that's, eye-catching or something that has a really big impact on somebody's self-esteem.
Right, of course.
Yes.
And to address that and correct it. And it can be life-changing. You might minimize that compared to like the work that you're doing
Well,
with,
it's a bit different.
cardiology and that sort of thing is so important.
Yes.
But our mental health and our physical appearance interplays so much with, our own like health, mindset, our ability to overcome things and changing something like that, maybe for a woman whose belly is stretched out and floppy after like, sacrificing that for her children.
Yes.
Can be a really big life changer. It's
Sure.
not
No
it's
doubt.
not just a pursuit of some perfect Hollywood ideal.
Right. It's a personal self improvement or enhancement when, as you said, a woman has been multiparous and has had, unfortunately, excess paniculus, I suppose, right? Extra skin and so on. But the important thing, what I hear from you, is you really care about the inner health of an individual. And then the more external aspect, what people see, can really go with it. But clearly you have to, in my mind, improve that inner health, all your metabolic parameters, mental health issues, your personal choices and behaviors.
Yes.
And then if you do have the cosmetic enhancements, then it can really be creating a human being or a person that's poised, confident, not arrogant,
Right.
a person who is eager and able to engage with whoever in a very gregarious and self-fulfilling way, right? Where you're getting your little dopamine spikes throughout the day because you feel great inside. You have inner beauty. You have outer beauty.
Yes.
Without competing with anyone else,
Right.
without trying to live up to some Hollywood standard, as you elucidated. But lastly, to say, I can do this. And, we all need help here and there. There's nothing wrong with asking for it as long as you have, good guidance. Now, if you go beyond that, have you noted or seen people who become addicted to plastic surgery?
Absolutely.
And what does that look like? Or how do you deal with that? That
Right.
must
How
be
do you
difficult.
how do you handle those situations?
Have you ever watched Botched?
Well, 1 or 2 segments a long time ago.
They always feature at least one person who's like the plastic surgery addict, but
Yes.
it does show up in my clinic in ways, and it is difficult because you have to do this dance of the psychological aspect of it, and you don't want to further harm them by addressing the fact that that there's a mental health problem going
Right.
on. But as a doctor, I think it's also my duty to recognize that and educate them somewhat and encourage them to get help. I have had clinic consults that ended in me telling somebody, you need to love yourself a little bit better and be less harsh on yourself when you
Right.
look in the mirror, because what you see in the mirror and what I see looking at you, they're not the same.
They don't match.
And if
Body dysmorphia.
absolutely.
Yes. Right
And
now.
one of a great ways that a great
By the way,
mentor.
that's a Greek word. He's Greek. They invented that word.
Oh, I'm
Yeah.
sure.
They invented a lot of words,
All of them.
right?
You just stole my thunder. That's supposed to be my line.
I'm giving you kudos.
Is it really though?
Yeah.
It's a Greek word.
If not, he'll make it
Dysmorphia.
up.
No, it is. It
Don't
is.
worry, he'll make it up.
A Greek
I
word.
Go on.
never. I'm happy to give credit to the Persians or the Romans.
But it's true that people have this body dysmorphia, and
So a really good tool to actually screen people for body dysmorphia is to ask them, like, let's say they come in for a rhinoplasty consult, okay? And
Just for the ignorant here, what rhinoplasty specifically means?
changing the appearance of
Nose
the
job.
nose. It's
Okay.
a nose job.
Okay.
So patients come in for a rhinoplasty consultation.
Yeah,
I just looked
right.
at his nose. I mean, you might
You're
have a
evaluating
candidate
it?
here.
Your nose is beautiful. It fits your face.
Thank you.
Oh, my
Thank
God,
you. I got a
Lindsay,
big
I'm
head. I
trying
need
to
a
get
big
you some
nose.
business.
So we ask the patient, so we say, rank your nose from 1 to 10, 10 being the aesthetic ideal, and 1 being worst deformity, eye-catching, like even children stare. And then you, in your mind as the physician, you have your concept of where their nose falls. And if their rank is wildly different from what the average person would rank that nose as, then that's a pretty good tip-off that they are dysmorphic.
Right.
And you should never operate on that person.
Right.
Even if they have some aspect of a deformity to their nose, you should still be hesitant about taking them to surgery before they get the psychological aspect of it addressed.
Yeah. So all you boxers, martial arts professionals, come on in. You probably do need it. It's real.
Yes. We see a
Professional.
lot of that.
So, what kind of plastic surgery do you find that you do the most? Is it random? Is there a statistical profile? Walk us through that.
It's a little bit of everything, to be honest. I only do aesthetic surgery. I don't take insurance. I'm cash based, and we can talk about where healthcare in America is
It's
headed.
going, yes.
Anyway, it's kind
Right.
of going that direction, probably for everybody.
In
anyway,
many aspects. Yes.
um,
I came up with a model of how to fix it.
oh,
We can talk about it
we'll
later.
have to talk more
But go
about
on,
that.
go on.
But I do aesthetic surgery from head to toe. I love working with, women who've had kids and want mommy makeovers. Like, I just really jive with them.
Right.
In this town, you have plenty of work.
Yes. And I just think it's I love helping people who, in my mind, have a real problem.
Sure.
Yeah.
And so seeing somebody who I see the appearance of, deflated, sagging breasts after breastfeeding, or some women are congenitally born with deflated, sagging
Right.
breasts, even if they've never had a kid or never had weight changes.
Or they had too much tissue, and with the pregnancies,
right.
they got bigger, and then that created various new deformities. Right?
Exactly.
I always think of the scene in Something About Mary when you mention that.
Yes.
Oh, because she was an orthopedic
Great
surgeon,
great
wasn't
movie.
No. There's the scene where the PI thinks he's seeing Mary
Oh,
naked,
that's
but he
right.
gets the
It
old
was-
lady,
Uh-huh.
and that's
The
exactly
neighbor.
what you're talking
The
about,
neighbor.
right? Yeah.
Mhm.
Yes.
So, but also some of my happiest patients are my facelift patients, and brow
Right.
lift and rhinoplasty, and so I enjoy all of it. I think surgery is problem solving, and I like problem solving.
Right.
And I also get to meet a lot of really great people and cool people. Just yesterday was a day that just like filled me up because I met so many wonderful people in our office. And I just felt so full just meeting people with like similar mindsets, people that take care of their bodies, that exercise, that eat right. And they're just coming, to optimize themselves. I think in a day and a time where people are more aware and conscious about longevity and taking care of their bodies, we
Right.
have to catch their external up to how long we're living.
Absolutely.
Do you do a lot of old people, like helping them look young?
Elderly.
Absolutely. Yes. Yes.
And
All ages.
what is the surgery? I have heard that there's a surgery that a lot of men are doing, like under the eyes or something. Is that, you know what I'm talking about?
It's probably a lower blepharoplasty.
Yeah.
For like, there's different issues you can have with your lower lids. You can have basically fat pseudoherniation. So you normally have 3 fat compartments.
Say that again. Fat.
Pseudoherniation. It's not like a true hernia but it's just it's like attenuation of like the stronger structures in your face, and it gets lax and kind of billows with age. And then you have these normal, like that everybody has from birth, 3 fat compartments in your lower lid, but they can become more prominent, more obvious. You can get wrinkles and basically excess skin or appearance of excess skin in your lower lid. And so a lower blepharoplasty, which a lot of men do benefit from, is a combination of removing some of he's really trying to sign me
No,
up for
seriously,
surgery.
look at this. You've got like puffy lids, right? You're not a drinker. You sleep well, right?
Yeah.
So you don't have bad habits. Your diet is fantastic, at least this year, right?
Drink water.
But-
Hydration is important.
But are aging also,
Right.
right? There are genetic components. Maybe you
There's-
lost some collagen and
genetics are huge for how the face ages.
yeah.
There are certain races that are actually very genetically blessed when it comes to aging, and Hispanic and Asians tend to age beautifully.
I see a lot of African American patients that I have, Lindsay.
And African
They
American.
look phenomenal.
They
I
don't
see
have a
some
single wrinkle.
guys and ladies in their 70s.
Black don't
You
crack.
what are you? 74? No way. You're 54.
Uh-huh.
Right? They are beautiful. The
Mhm.
skin is just shining, beautiful quality, no wrinkles.
My husband's family is like that
Yeah,
too. They
some
just like
from
they
Middle
don't
Eastern
age.
people.
They look 20 years younger than
See,
they are.
I have Middle Eastern blood. I have Spanish blood.
What's your Middle Eastern?
Well, this is from Spain because of the Moors that
Yeah,
were there
got
700
it.
years,
Mhm.
right? And where my family's both sides. I have Native Mexican and Native American.
Hmm.
So I kind of have good skin, I'd say.
Well,
Yeah.
Good genetics.
you don't look 64, Fred.
No, thank you.
Let me ask you something.
Yes.
So I was told my entire childhood that I was American Indian, that I had Cherokee Indian blood in me.
I have Cherokee blood.
Have you done your 23andMe?
No.
I did my 23andMe and it came back 0%
Zero.
American Indian. And so I was like, well, that's curious because it didn't really match up even with like what I've seen in my family and like genetic traits. But then somebody told me, and I can't verify this at all, I'm really asking if you've ever heard of this, that they pulled the American Indian off like the 23andMe registry for some political reason
Yeah, I had.
or some practical reason.
I have not heard about that, but I'm not well informed on the politics of that.
Yeah.
You know, it's more about what your parents have told you and so
Right.
on. And of course, you can prove it or retest with a different company
Mm-hmm.
that maybe has a different or more broad-based genetic inputs.
Did you hear about the hacker
No.
that is selling the 23andMe data?
No.
Oh, really?
Yeah, that just came out.
That's
Yeah.
terrible.
What are they doing with it?
I don't know.
Well, I mean, you can see it going to insurance companies
Right.
for disease,
Oh, gosh.
to employers,
Uh-huh.
to various government agencies. It's no good. Right? It's a private matter.
That's horrible.
If you want to share it with somebody, that's your choice.
That's a huge breach
Yes, a huge breach.
of health data.
So in the plastic surgery world, what I have seen, and speaking about blepharoplasties, that I think
I'm the poster child now.
Speaking of
Yeah, speaking of this, a future blepharoplasty in need individual here.
Should I ever do it, I'll use
but no,
you.
but listen, the microsurgical techniques that the younger population of surgeons has is far superior to what my generation, I don't mean that in any disparaging way, and also the recovery time is so much shorter. So tell us.
Well, so one of the benefits of training in the era that I've trained is that plastic surgery is a relatively new field, right? But I have literally been taught surgery by people who have been practicing for 20, 30 plus years. And so I get to learn a lifetime and a career of wisdom and
Yes.
development of these techniques. And so it's a great time to enter the field because I basically don't have to make those 30 years worth of mistakes
Right.
that my predecessors did to get to a point where they have like
And-
really reliable and predictable results.
Yes. And again, some more learning from that wisdom, applying your techniques, better instrumentation, better, I guess, more, what is the word? Less invasive?
Mhm.
Is that the word?
Yeah, less invasive, just understanding tissues and
The
what they
tissues.
can handle and being gentle with them.
Because we've all seen the mistakes of the past. I mean, they're
Mhm.
all over social media, right? Facebook and Instagram, of the older movie stars, the older generation,
Mhm.
predominantly them, or musicians and others, where it's horrifying to see. I
Mhm,
don't want to
it
name
is.
names. We know who we're talking
Right.
about, but it is alarming.
Overfilled, overpulled.
All of it, right?
Yes.
And it's sad to see because we occasionally see someone in their 80s who unfortunately perhaps did not get someone like you, a younger generation surgeon with better techniques or more. I would call it respect for the tissues.
Right. Absolutely. Respect for the tissues, understanding the anatomy, and then also trying to keep people looking like them.
Yes.
And I think that's really important because I think the psychological impact of somebody looking in the mirror and seeing a completely different person after, 60, 70 years of life is not good.
It's alarming. And unfortunately, for some people that depend on their looks, like some actresses who have gone overboard, when people like them the way they were, because
Mhm.
imperfection is
Right.
beautiful
It
still,
is.
right? Like
Mhm.
we're not,
Uniqueness,
Yes.
unique beauty.
and they get it all done, and all of a sudden, roles are gone.
And
You
so
don't look yourself.
this is a problem, I think, in our industry right now. A problem that we're facing is what's driven a lot by med spas. And when you have this, like, when people are trying to sell filler, and the more
Yes.
filler that they sell, the more money is in their pockets.
Yeah.
And so if a patient asks for something, they get it because that means one more syringe and however much,
Yeah,
more
another
money.
$1,500 or what have you. They're not cheap.
No, they're not. But then you end up with people who have not been evaluated thoughtfully.
Powerful.
And they
Yeah.
haven't been evaluated with the principles of what makes an aesthetically pleasing face. It's just like, can I fill this? Like, yes, I'll charge you. Yes, I'll fill this. And it's not from an educated standpoint. And it's creating an entire group of women that look similar,
Yes.
and they've lost their unique traits.
That's a great
and I think that's a
point.
horrible thing to happen.
Yes. Do you think then the med spa overuse of Botox, fillers, and perhaps other techniques, the Euro threads and things like that, is being overdone by people who do not have the expertise to be doing it?
Absolutely. The people who don't have the expertise, nor who who even are legally allowed to be injecting.
Right. So it at times goes largely unregulated, this
Very.
industry.
Mhm.
What should happen? Like if you had a magic wand and had the wherewithal with the medical boards, not only in Texas but across the US, what would you do? If you said
Cool.
this is the rule that the American College of Plastic Surgeons, American Medical Association would get behind it.
Well, one, I would say that, right now, I think the standard is that you can run a med spa by people who are not physicians, as long as you have a physician sign off on a certain percentage of your chart. But that physician can be a family medicine doctor.
Right.
It can be an ER doctor.
Yes.
It can be a neurosurgeon.
A cardiologist.
Cardiologist.
Yes.
And so you lose that oversight and the education. So in my mind, the only person who truly has been trained to understand the anatomy of the human face and to understand long-term consequences of injecting. Like, for example, I can tell you right now, like
You were
You're-
looking at my six pack.
yeah,
Huh?
your
See, Roderick. What okay? See, and I think, do I need some Botox? You think?
you do.
I do.
Absolutely.
Lindsay, I'm coming to you tomorrow.
But an example is lack of foresight in injecting, for example, the lower lids. It's not that I have not injected lower lids before, but it's very conservatively and in very few instances. And it's because I know as a plastic surgeon that the lymphatics of this area of your face are so sensitive, and you could really obstruct them and cause issues for the rest of somebody's life.
Right.
So
For the rest of their life.
For the rest of their life.
Wow.
So a 20-year-old can go in and just say, "Oh, I think I don't like how this looks. Like it looks, I'm seeing a shadow." When I take pictures, then I look at people come in and they show you their Instagram and they say, not, "Hey, look at me as a human. I want this fixed." They say, "Look at my picture.
Right.
I want
Wow.
this shadow gone."
Right.
Yes.
And so what I'm getting at is that the oversight that you need to have in a med spa is somebody who understands facial anatomy surgically, a plastic surgeon who can then oversee and train and teach injectors.
Yes.
I'm
Are
not
there
s-
enough of you though to meet the demand and need
Probably not.
in the United States, Canada,
Do
and
you-
Western
Do you,
countries?
do you have any med
Yeah.
spas under you?
I do not. It's not that I wouldn't ever have one, and it's something that I will probably develop, but I want to do it in a very thoughtful way.
Sounds like you should.
Yes.
Yeah.
Sounds
Well,
like we need you
well,
there
I mean-
because there's so many unregulated med spas I know in this town.
Mm-hmm.
But there are she's coming from a very ethical platform.
Yeah, that's why I'm saying.
Yeah, that's who she
Right.
is. So that's what I get from you, Lindsay, that you're saying it's not, we just have to do it correctly.
Right.
We need the expertise, the supervision in order to not harm people,
Yes.
short or long term,
Yes.
right? Now, another question. Dermatologist. You guys
Mm-hmm.
work with dermatology.
Mm-hmm.
They're very well trained. They're medical doctors. They do long residencies. Like most of us, they've put in a lot of time.
Right.
They're very good at what they do, especially detecting skin cancer early, treating it. I'm sure you've had people with various type of skin cancers, whether melanoma, squamous cell, basal cell,
Absolutely.
and others. And so you guys work readily with them, right?
Mhm.
And you share patients at times,
Yes.
right?
Commonly.
So how does that relationship in the new era, how should that be? How
It's
should it work?
interesting. Dermatologists used to be the plastic surgeon's best friend because they didn't really overlap into the aesthetic aspect of the industry. And so they would be a source of referral for a plastic surgeon.
Right.
And so obviously, selfishly, you want that source of referral. Now, a lot of dermatologists perform injections, and I would not say across the board that no dermatologist should inject. But I think people need to understand what their training is. They're not surgically trained
right?
outside of Mohs surgery.
And Mohs surgeries,
In
right.
Mohs surgery, and even so, that's a very
MO
spec-
surgery.
She's
So-
the expert.
So Mohs surgery is an approach to skin cancer where it's meant to minimize the amount of tissue that you take away and the defect that you create. And so it's indicated for skin cancers that are in cosmetically sensitive areas. Like, so for example, like the lower lid, very, very sensitive area to operate on because you affect the eye and exposure of the eyeball, et cetera. So if you have a skin cancer here, you'll go to a Mohs surgeon. So if you go
Okay.
to a traditional, person to cut out that skin cancer, they have a set margin that they just cut out around the skin cancer. And they're like, that's the margin we need for this diagnosis.
Right.
And we close it up. And they don't care about the defect that's created.
Got it.
When every millimeter counts, you go to a Mohs surgeon and they basically minimize the margins and they take that tissue, they take it to the back room, they put it under a microscope, and they actually look at the cells and they just cut minimal amounts until they have a clear margin on microscope.
Wow.
And so you're minimizing the amount of the defect that you
The
have.
scar, yeah.
Mm-hmm. So most surgeons are trained in surgery, but even so, they're trained in, like surface surgery,
Right.
Dermatologists are not trained surgeons. And so basically it's just different. Knowing the surgical anatomy of a face is very different. Being intimately aware of the different layers and having operated on
Right.
them and, perform facelifts and like eyelid surgery, it's different from somebody who's basically just trained in skin. And so
Sure.
I know that there are fabulous, wonderful injectors that are dermatologists.
Right.
It is, however, a slippery slope because just yesterday I was made aware by some colleagues in plastic surgery of a dermatologist who is performing body contouring procedures.
Right.
And
So is that fat transfer stuff or
mostly they were advertising
Liposuctions?
liposuction,
right?
liposuction, like tummy tucks, that
Right.
sort of a thing. And then there was like this big fight that broke out like on this Instagram post where all these people were saying, how dare you criticize him? He's fellowship trained in cosmetic surgery. So this raises the question, nobody actually understands training and what sort of training actually makes you capable of performing plastic surgery procedures. So he had all these followers who said he's a legitimate, plastic surgeon because he did a cosmetic fellowship. Well, what they don't understand is there's no legitimate fellowship that is plastic surgery training for a dermatologist.
Right.
You can pay somebody, not be accepted on merit.
Right.
Or the fact that you already had a surgical training and understand anatomy. You can go to
A course, right?
A course.
For a weekend or a week-long course.
To be honest with you, some of these are a year long. And
Right, I
you
see.
pay a plastic surgeon to go into their operating room and watch them
And
operate
learn
for a year.
from them.
But how would you like the person who you're trusting with your surgery that you're putting a lot of your time and your investment in your recovery into?
And money too.
Yes, absolutely. Your
Not cheap.
finances, your time, and then you find out that this person did a skin residency and then went and paid somebody to watch them for a
To
year.
follow them.
And then that's how they learn
Right.
surgery.
Yeah. So
And I imagine
it
the
can't
people.
compare.
I imagine the people on Instagram that were getting defensive, but they didn't want to face the fact that
Or
their
they
person
didn't know.
Right.
Yeah.
They didn't know.
Well, or they're misled.
They're misled. Yeah.
They're misled.
The advertisement is misleading.
Yes.
Nothing compares to someone who's gone through an authentic residency fellowship to its successful completion.
Right.
Okay, nothing substitutes for that.
How many years was your residency?
6 years.
Yeah.
6
Yeah.
years.
Mm-hmm.
So you
Yeah.
spent more time just doing the
Well,
residency.
She did medical school and then
Right.
all of that
Right.
because they have to do general surgery for a while and then they jump to the plastic surgery branch.
So traditionally, the way to become a plastic surgeon
Yeah.
was, before plastic surgery was really big enough of a division to have its own residency, it was traditionally fellowship, but it was a 3-year
3-year,
fellowship.
yeah.
And so you would do 5 years of general surgery,
then-
graduate as a general surgeon, and then do 3 years of plastic
Right.
surgery. Well, as the field grew and as the demand grew, people realized that it wasn't the best use of time to be doing gallbladders
For 5 years.
years
Right.
before you start learning aesthetic principles.
Yes.
And so now they have what's called integrated plastic surgery programs. And so I still did general surgery rotations, like, for example, trauma rotation at Parkland. I did ICU rotations. I did burns ICU.
Yeah, you did medical stuff.
Yes.
Medical surgical.
Yes, and like
Yeah.
critical care,
Yeah.
understanding
To
like
understand
really important
complications.
complications,
Yes.
physiology,
Yeah.
and how to care for a sick patient, because any of us can end up with a very sick
Right.
patient.
You have someone in the ER coming with a 3rd-degree burn who also had some prior deformities.
Mm-hmm.
It's infected. They're febrile.
Right.
You need to handle that.
You have to be able to handle it.
Yeah.
So I'm very fortunate, again, at the time that I entered plastic surgery, that the integrated system already existed, because I had my hands into aesthetic surgery and learning aesthetic principles from year one.
Okay, great.
And so I actually have 6 years of plastic surgery training. Like
Actual
I
training,
have
yeah.
been operating.
But
for
that
6 years.
dermatologist did a fellowship for 6 months.
where they didn't touch a patient.
Right.
Yeah. So a couple of areas that I see that are being overdone currently in the U.S. Lip injections,
Yes.
often not by trained individuals, especially in young women.
Mm-hmm.
And please elaborate on that, because all I see, I don't think men like those.
I don't think so either.
I think we find it very unattractive. I can just speak for myself.
I mean, Howard the Duck is what I always think of.
I think
Yeah.
women do it for other women. I think women get lip injections as like this comparative thing to other women, because they have this like false concept that you take a feature that can be attractive, if it's plump, like Angelina Jolie, naturally beautiful,
Right.
plump lips.
Yes.
And they want to mimic this.
But it doesn't look like that at all.
It does not.
It does not.
It
yes.
does not.
So
And
yeah.
in my practice, we actually we won't hire anybody in my practice who has a lot of filler or lip filler,
Oh, wow.
because, and I'm not saying we don't do lip filler, and I have had lip filler one time 6 years ago and just chose not to do it again.
Was that just to try it out and see what it was like, or you felt that
I was curious.
Yeah.
I thought that I could benefit somewhat from it.
Right.
I did it very conservatively, and then I just decided that there's a
8
risk.
syringes in there?
Yeah. there's
Eighth of a syringe.
I always worry about how something is going to age and how something's going to change.
Yes.
You know, lip filler can change your anatomy permanently as well too.
How so?
And well, so you form scar tissue around any object that's like injected into
a
your
foreign
body,
object.
right? It's a foreign object. And so
Yes.
you will always have some scar tissue. And I am a big proponent of lip filler in the right women. And a lot of those women are either born with minimal to no like lip show. Other women are women who have aged and they've lost volume, they're deflated, and they just have a thin line and you can barely see their lips. And I personally, my preferred approach is actual a dermal fat graft to the lips, where I use their
From their belly?
C-section scar.
From their
I use a
yes.
C-section scar and I take fat with dermis attached to it, so it has a structural component.
Yes.
Okay.
And then you make a little nick here and a little nick here, and you pull it through, and it gives a much more natural look, and it's semi-permanent. It might resorb with time, like anything in the body, but you will get
3 to
some,
5 years later,
yeah,
maybe
but
they
you'll
need
get
more.
a nice change, and
Right.
it looks natural.
That's interesting. So that's the other procedure that's going on, the fat transfer to the face, often by people that do not have training
Right.
or a whole residency fellowship, but rather went to a weekend course because they can make a lot of money on a fat transfer
Right.
procedure, right?
Mm-hmm.
And often it's being done around the eyes,
Yes.
right?
Mm-hmm.
To elevate cheekbones.
Areas. Uh-huh.
Get rid of nasolabial folds like I have, which are genetic. I think I've had them since I was a teenager.
And see, here's the thing.
Yeah.
I don't think nasolabial folds are inherently bad.
No, it adds
And-
character to my face.
Well, it's also
If I looked flat, I would look like expressionless.
right. The
You know, my
full cheeks create a heavy nasolabial fold,
Yes.
and that's just part of you having nice cheeks.
yeah, my Native American cheeks. You see, kind of cheekbones.
I think when people want to
fall.
efface every line,
Yes.
you know, and every shadow, it's not an aesthetically pleasing look.
What you want is the symmetry, right? Isn't that symmetry beautiful? I've heard people
Ooh,
say that.
there's
Is
a
that
big
wrong?
Argument about
Yeah,
that.
so
here we go.
Please tell us. Is symmetry beautiful?
There's almost no human in nature that is symmetric.
Except for Liz Taylor and Denzel Washington.
Yeah. But the thing is, how many other people that you know who are beautiful, who are asymmetric? And so many people. If you take your face and you cut it in half and you mirror image one side to the
Yeah.
other, and then you look at those two, you'll find a completely different looking
Sure.
human. Everybody has a short, wide part of the face, and everybody has a long, skinny side. There's a lot of mandible asymmetry. One side is, shorter like this, the other is longer. And this contributes to, how people have a good side
Yeah.
for the camera.
yes.
It's real.
Right.
It's a
It's real.
real thing because you do have one side that probably is more towards an aesthetic ideal and
Right.
more aesthetically pleasing than the other half.
Now, are you guys using AI at all to help you? No.
But-
I don't think AI can ever replace.
See that? Let me jump in that one.
Please.
There are image-based professions in medicine. Obviously, radiology. We're going to have AI that can read 10,000 X-rays for a hospital in one day
Better
at a
than a
minimal
human.
cost. Well, I'm going to say this. What I think is that the radiologist then comes in when the AI flags the abnormal ones and says, okay, out of these 3,000 X-rays this month, we've got 300 of them, say 10%, that have genuine issues.
Right.
Where now the radiologist comes in and says, here it is. Let's talk to the patient because they're going to need a
Right.
CT or an MRI or a PET scan or what have you, because I'm concerned. And yet, it could have been missed. So maybe 2, 3, 7 out of 10 in some cases of the radiologist would have missed that lesion because the AI is analyzing it from a bank
Right.
of 10 million X-rays with those pathologies. So I think it's going to enhance the profession. It's going to make the
sure.
radiologist even better. We may
Probably
need
so.
fewer radiologists, but they're going to be better. Same with the dermatologist in detecting skin lesions. Is this a nevus or is it a precancerous lesion?
Right.
Take a photograph, the computer analyzes and sends to the dermatologist and says, you need to come in.
But I don't think you can ever replace that spidey sense. that
No, exactly.
patients themselves
Yes.
have and doctors have in
Yes.
regards to something, because sometimes patients will know, I know this doesn't look right, but something's
Right.
wrong.
Something's wrong. And
Um,
you're absolutely
And
correct.
some
There's a
doctors can pick up on that too. They're like, something's off,
Yeah,
even though
it's
it's
not
not
right.
apparent.
correct. So I think some of them, I'm looking for AI to enhance and
Right.
improve quality.
Agreed.
Sure.
And I think we'll have it. In my field in cardiology, do I need to look at 25 echoes today and sit and write 25 reports when the AI can go, this one, the left ventricular ejection fraction, the aortic valve has this, and that, and I can go, okay, I do need to look at this one. So from 30, I'm really looking at 5.
Right. Which could improve your quality of life.
Not only that, but here's the other part. I did presumably do a physical exam, and I go, okay, this doesn't match, right? There's something there, and the patient said he was playing tennis and he couldn't make it past the first set, was short of breath, came in, blah, blah, blah. AI is saying, but no, my spidey sense says, no, this is a constricted pericarditis issue. And even though the echo doesn't show it, because that's the limit of that technology.
Right.
Right?
Interesting.
And I know the patient had pericarditis in his 20s or her 20s. Now they have a constricted picture. So what I actually need to do is this test,
Right.
and that's your spidey clinical sense.
Right.
Nothing replaces clinical
No.
Yet.
savviness.
Yet.
Never. Right?
Yet.
No,
Yeah.
seriously. I think
Yeah,
AI will
We
enhance.
say this.
Correct? We concur?
I concur completely.
Clinical acumen, and you build it over years. You have to have the right professors. Sometimes they whip you to submission because it means you didn't do it right, and you got to go back or bring an article that supports what you're stating, and then they're going to criticize that article that it wasn't properly randomized, and you're picking a non-peer-reviewed journal.
Right. And that's what board certification is for, right?
There you go.
Because it's meant to like make you think critically.
Yes.
And have holes be put into your arguments, then have to like justify.
And then you justify it in front of people who may be 20, 30 years older than you, and you're going, no, the reason this topic or this patient, we're doing this, look at the published data, and this is why we think we should do this.
So something that I had in my residency, which my residency is actually kind of famous for, my residency was the #1 program in the nation. And
Was that in Atlanta as well?
No, in UT Southwestern.
Oh, UT Southwestern, yes.
Yes.
Yeah.
So they're like, the standard for plastic surgery. And we have this famous conference that's every Thursday. So for 6 years, every Thursday, we go to conference and we take a list of everybody, every case that we've done for that week, everybody that we've operated on and the surgery. And they randomly choose one of the surgeries that we performed over the past week. We have no idea which one is coming. And then you have 7 minutes and you get grilled. You get asked about the patient's history, whether or not you actually know their history, their health. Did you think about everything before you took them to the operating room? Were you thoughtful about indicating them? Were they somebody you should have never indicated? How did the surgery go? Was there anything that you would do differently? And then you have to support this with literature.
That's wonderful.
And this is every Thursday.
But
for
That's like
7
honing
years.
you like a whetstone.
Yeah, and sometimes you're going to come up on the raw end of it, but in time, you will improve your skills all around.
Right.
And not just say, well, the check got cashed.
Right. But if you're doing this every Thursday for 6 years, you get into a habit of when you think about every patient that you're operating on, you think about all these things.
No doubt.
You think, am I doing right by them? Have I indicated them correctly? And if I have to stand up before the medical board, can I rationalize and say I did everything in my power to make sure that this person was safe?
Absolutely.
It's like the concept of the panopticon. If you don't know, if you think you're always being watched, even if you're not, you act like you're always being watched. And so that's only going to make you keep your level up. That's wonderful.
Yeah. I went through a similar program at Baylor College of Medicine in Houston, and both internal medicine and then cardiology. And when I was chief resident as well, I would take the students through that. And, it really makes you better. I had the privilege of working with people that some of them sat on the FDA board, some of them wrote the book on diabetes, others on cardiovascular topics, including, of course, nuclear, echo, the heads of the American Society of Echocardiography, American Society of Nuclear Medicine. We started doing the research on cardiac MRI, CT, PET scan, all of that. And, I got
Giants
to work
in the field.
under Michael DeBakey as well, who
Incredible.
was...
Everybody take a drink. He mentioned Michael DeBakey again.
Yeah. So
we use DeBakey's in the operating room. We have a
Yes.
surgical instrument
You
that's
do?
called the DeBakey.
The DeBakey, yeah.
Uh-huh.
So he actually, I took care of him a bit,
Did
So
you
I
really?
got to know the whole team.
How neat.
Yeah. So that's a whole different story about Michael DeBakey, but
That's
he was
actually very
a
cool.
giant. So I got to see Boris Yeltsin's heart and all of that when
Wow.
our team went to Moscow.
Wow.
When he had a cardiomyopathy and so on. And I got to see all kinds of celebrities working under that
I
team.
get more excited about like surgical celebrities than I do like real celebrities.
Yes.
I'm like, you met who?
Yes. So, the Texas or the Houston Medical Center has St. Luke's and Methodist.
Mm-hmm.
And of course, at St. Luke's was Dr. Cooley,
Okay.
who had trained at Hopkins during the Blue Baby era. So he was one of the fellows who
Wow.
learned how to help kids with tetralogy of Fallot, congenital heart disease, transposition
Wow.
of the great vessels,
Uh-huh.
and other such malformations that unfortunately resulted usually in the death of the child. So they came together, they formed the Baylor College of Medicine at the time, the cardiovascular side, and then they had a falling out at the time when they were developing and trying to develop the artificial heart and all that. So I came a little after that. I got to meet both, hang out with both
Incredible.
when I was in cardiology. So it was really a great experience. So the surgeons in those hospitals are, I don't want to use the word gods because that's a negative connotation, but they are incredibly well respected.
They did incredible
worldwide.
things to advance their field.
There you go. Yes, the grafts, the valves, surgical techniques. At any one time, our ICU, surgical ICU, had over 150 beds.
Wow.
Yeah,
In an ICU.
and our ICU over here, that was just a post-op, ICU. The
Wow.
coronary, the cardiovascular was separate because we were such drawing a place where people from all over the world would come, including Middle East, Saudi Arabia,
Mm-hmm.
South American presidents and celebrities
Mm-hmm.
over here. So,
So go ahead.
I think it's incredible because, who trains you and the people that pass along their profession to
Yes.
you make such a big impact on you. And that's
Absolutely.
one of the things that always drew me to surgery.
yes,
It's like so cool to me that I didn't learn my trade from reading a book. I learned from humans who did amazing things
Right.
to advance the field. And then they chose to dedicate some aspect of their career to then training me.
to teach you, yes,
And
and influence you
such-
to go seek for answers.
Yes.
Right, curiosity.
yes.
Correct.
Okay, so I have a question for you. Very, I'm ignorant about all this stuff. What's the deal with? I had a friend of mine. She recently had her breast enlargement removed
Mm-hmm.
because she thought it was causing some kind of autoimmune
Mm-hmm.
situation.
Yes.
She had them removed. It has not changed her situation. It probably
Right.
wasn't that at all.
Right.
There's a lot of disinformation about that.
Mm-hmm.
What is the truth? Please tell us right now, what is the truth about silicone versus saline versus it's all just in your head and it's probably another issue and you're
Right.
just blaming that?
I
The
have
floor is yours.
a very large passion for talking about this topic compassionately. And I think what a lot of people are missing is truth with compassion. Because I know what I know from a scientific perspective, and I think it's really important for women to understand the science so that they understand the truth, but also not to be shut down as like crazy either, right? Because a lot of people, you're in one of two camps. You're wrong. This is all in your head. You're just a little crazy. Or there's like, oh, we believe in breast implant illness is the label that it's been given. So I'll tell you the truth.
Okay.
The truth is that one, silicone and saline implants both have a silicone shell. So in my mind, I don't think there's any difference. You still have a silicone object in your body.
Right.
It's just a difference of what's on the inside. Now there are different things that behave differently from them, but if you just want to get down to the nitty gritty of what you're putting in your body, it's a silicone shell. So what a lot of people don't know in this day and time is that implants were taken off the market in the 90s, and it was in order to investigate this question. And so implants were off the market from the 90s through I think 2006 in order to look at this. And it was not plastic surgeons looking at it because that's a conflict of interest, but these were a lot of medical
Medical people,
societies. And so a lot of
Rheumatologists and
exactly
autoimmune
they looked
Disorder.
at it, and after over a decade of
Yeah.
collecting information on these women, they found there was no reliable association
Yeah.
between systemic illness
No.
and breast
None.
implants.
Yeah.
No reliable.
Yeah. No
association.
causality. No
No,
causality.
there were these stories of women who had, rheumatoid arthritis or some
Right.
autoimmune disease, and then the more they interviewed them, they actually had evidence of it before their implants, or had even been
Yes.
diagnosed before their implants.
Yeah.
But there's an update to that. So then social media happened. And so there's this new wave of women thinking that they are figuring this out for the first time, because it's the first time women have talked about it on Facebook groups
Sure.
and on Instagram.
Right.
And all these women are saying, I have implants and I'm experiencing systemic illness that is impacting my life, and I am searching for answers. And here's this thing that I did to my body, and now I have remorse because I think this might have hurt my body. And so the Aesthetic Society has actually started a whole new research campaign. They funded a research campaign to give some more like thoughtful answers to women that think they have breast implant illness, and to kind of relook at it again
Right.
with better studies. And so over the past few years, our society's actually worked with people who are also medical people, like labs at Johns Hopkins,
Right.
places that do not have a conflict of interest, so that you've kind of eliminated that from the situation. And we've done biopsies on women's breasts, who have never had an implant in them, and then biopsies on women's breasts who have implants in them. And they looked at a whole profile of things that are all things taken from women who believe in breast implant illness in order to address their questions. So do they cause heavy metal toxicity in your body? That's a
Right.
question. Are there heavy metal toxins in these implants? And the answer to that was women's breast biopsies who had never had an implant had the same levels of, metals as a woman who had
Because
implants.
the fat absorbs that.
Right. And so, interestingly enough, the one significant association that they found, or at least trended towards significance — I don't remember if it was significant or not because their population size — but they found an association between cigarette users and heavy metals in breast tissue, which
Right.
there's a lot of contamination
Of
in
course.
cigarettes.
Yes.
And they also diet specific, right? So certain diets have a propensity for having heavy metal toxicity.
A lot of
So
fish.
fish, rice, I think they found. And so these were the actual associations they found with that. Another really important question that they asked was, there are a lot of women that believe very stringently that if they have breast implant illness, let's just say for argument's sake, they have breast implant illness. If they have breast implant illness, when they have their implants taken out, they believe that you must get every tiny piece of capsule, which is just the natural scar that forms on an implant, every piece of capsule out in order to be healed from breast implant illness. Okay. So,
And this is just like a social media idea,
yes,
right?
Yes.
Okay.
yes.
Sounds pretty impossible.
The dangerous part of that is it's actually dangerous in many cases to go after all of those, because you're talking about taking a filmy little scar off of ribs,
Right.
off of perichondrium, off of the intercostal muscles, and you can easily end up with a pneumothorax, a collapsed lung,
Infections.
yes,
and
and bleeds.
seromas and so on.
Great consequence, okay?
Yes, complications.
Great consequence. And so we wanted to know, well, let's say we do want to help women in this population, okay? We want to have some compassion. If you want your implants out, let's take them out. But let's compare to see, in people who we've taken the entire capsule out with people who we don't take the entire capsule out, if there's any difference.
Right.
And our society found that there is no difference,
I already knew that.
and that there were some women who
Yeah.
just had some capsule taken out, whatever was like easily gotten without injury to the patient. They had similar feelings of relief after the surgery.
Right.
So then the other thing to talk about is that some women who believe that they have breast implant illness feel better once their implants are out.
Well, yeah.
It's a psychological component.
Psychosomatic.
Right. So the
Yeah.
Greek
mind-body
words.
connection is
Yes.
so powerful,
Yes.
right? And so I always I have women come to me who, believe in breast implant illness, and they, are looking to me for answers, and I tell them, and I print out the papers and I give them to them. I'm like, these are real studies.
Right.
And I say, this is what science says. Breast implants do not cause systemic illness. Another thing that I tell them is, some women, their bodies don't like their implants, but you usually see a local reaction at the
Right.
level of the breast. And so I tell them, if you don't have pain and discomfort or like a rash or something associated with your implants, there's no reason to think why it would cause a systemic response
Exactly.
if you don't even have a local response,
right.
because you should have local before you have systemic,
Yes,
right?
correct.
So I tell them, look, if your implants are soft, you don't have pain, you like the way they look, then don't take them out as the answer to your systemic disease. You need to work very hard with a doctor, nutritionist to seek the real answer,
Yes.
because you do have something going on that, needs an answer. Interestingly enough, I had a patient come in recently, and I'll keep it vague enough to keep her privacy. But at one point in time, she did think that maybe breast implant illness was a real thing, and she had implants. She took them out and didn't notice any changes in her life whatsoever. But then she lost 40 pounds, and all of her systemic illness went away.
So she had insulin resistance or metabolic issues.
Yeah, she was
It's
just
likely.
feeling the effects of being unhealthy and having,
Yes.
and those were her words. She said, I had very unhealthy behaviors.
Exactly.
And when I stopped them, all of my systemic symptoms went away.
Yeah, precisely.
So follow-up question to that. Silicone or saline? Which is better and why?
Silicone is better in my mind. So I'll give you the counter argument to that first, saline. So benefits of saline. Benefits are that when it does get ruptured, you know it, because all the saline gets leaked out and then it's inert to your body. Your body absorbs it. And then you can just visibly see. So you know
You're
you
just
need
thirsty
to go.
or something.
Yeah, exactly. So basically you just know right away that it's ruptured, and you know that you need to get it revised.
Right.
So that's actually considered a benefit, that you can see the rupture.
Do they rupture more easily?
Well, a lot of them are older. Not technically.
Okay.
Technically, they shouldn't have a higher rupture rate, as long as you're equating it to an implant of a similar generation and like time point. But saline implants look more unnatural. They feel more unnatural.
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 Okay.
They can be like heavier, and I think aesthetically speaking, they're not the best result. And
So you prefer silicone?
Silicone 100%. I only offer saline for very special circumstances, or if a woman has just had them before and is so sold on them,
Right.
and it's what she's used to and she just needs an update, then for me it's like that's the best form of informed consent. If somebody's already had something and they want it again, it's like, okay, we'll defer to that. But silicone feels more natural, looks more natural. Technology, even in implants, has come a long way with time. The shells are better. The gel inside is better. The downside is that a lot of times you can have a silent rupture, meaning people refer to a lot of the newer implants as like gummy bear.
Right.
The term is used kind of loosely, but basically if you cut down an implant, it's going to keep its shape. It's not just going to like splat like water, because the gel is form stable and very cohesive. And so if you have a little rupture in the shell, then you can't necessarily tell, because it keeps its shape in your breast. And so you do need to have, saline needs screening too, but silicone definitely, you need to have an ultrasound exam 5 years after your initial augmentation, and then every 2 to 3 years afterwards. But I do that for my patients in my office, and even for other people's augmentations if they want it. I have an breast ultrasound. I'm certified in breast ultrasound, and I scan to look for ruptures. Now, the reason why that's important is because once you do have a rupture, you should have it revised, because even though that silicone kind of stays in that gummy bear form, over time and like with any sort of trauma or pressure, it can leak out of that shell.
Right.
And the more silicone that you have that starts getting into the breast tissue, it just gets messier, and it makes revisions a lot harder. And it becomes a longer surgery, more expensive surgery.
What is, if there are no complications, what is the natural history of silicone implants? When
The life?
The life of it. Do you professionally advise, say, after X number of years, maybe we should put new ones because they've lost volume, or what
if you don't have a problem, leave them alone.
Leave them alone.
And I think, the companies used to say 10 years, that's like the lifespan, because they kind of have to throw something out there, right? Even a lot of like the ortho implants, they say our implant is good for 10 years. It's kind of an arbitrary number, just to cover themselves.
Right.
But
no studies on that to show that
because there's too many nuances to that, right? Like why something would fail in somebody and not in another. Breast augmentations are notorious for poor follow-up, because once a woman has implants that she likes and are working for her, you cannot get her to come back to your office. She's gone. She's gone forever. She's living her life with her implants.
Yeah, you have to go to the local strip club to find her.
Exactly.
I mean, you get a lot of those women coming for them.
That as well, yes. Every genre, from moms who want a conservative, fly under the radar augmentation to women who are strippers for a living. Yes.
Yeah. So is there a discussion? And, I know you're 118, 5'8", and you want ones that are 600 cc's each.
Oh my God! Just from the look in your eyes, I can tell you.
It
have
throws
this
your
conversation.
contour off. It's not the best for you.
How do you handle that?
I say big boobs, big problems.
There you go.
The heavier an implant, the harder it's going to age. I mean, we all understand the concept of gravity and sagging skin with age. Well, it's the same for an implant. The heavier your implant is, the more stress it's going to put on your native breast tissue. It's going to thin it. It's going to stretch it. The quality will be lesser. And then it'll also drop more with time compared to a smaller breast. Now, I will say, aesthetic surgery is elective and it is for an aesthetic appearance. And so I have patients who very confidently want larger breasts, but I just spend more time with them on the consent side. And I won't put anything larger than I think their body has the capacity to handle. Like if it doesn't actually fit, I won't do it. But if a woman comes to me and has had large implants before and they want another set of very large implants.
Larger than prior?
Yeah, but maybe
the same size,
similar or bigger, but just large implants. Then I say it's actually a pretty good informed consent process because
if they already had them.
If you've had them before and you've had them for like a decade and you tolerated them well, and you can look me in the eye and say, "Doctor, I don't have any poor consequences of these." Like they'll still age, but they'll say, "I don't have any back pain. I don't have neck pain. I don't have shoulder pain. My body supports them well. I'm doing well. I've always done well." Then I say, "You're an adult. You actually have experience with this. And so I will put in larger implants than maybe my preference." Now, my conversation with a 20-year-old coming to me talking about implants for the first time is very different than a woman who's
middle-aged
on her
woman.
third set of implants and she's tolerated large implants for years.
Right. So with that, we'll talk about the young girls in a sec, but often it's the husband that's pushing them. So men, common sense has to prevail. The health of the woman is first.
Red flag. That's always a red flag.
Yes.
If a patient comes in and their husband does more talking than them, I had a patient come in a few years ago who every time I asked her, "What are your goals? Like, tell me what you don't like. Tell me what you're looking for." She would just look at her husband and say, "Well, he probably knows better."
Yeah.
Oof.
And then he would tell me what he wanted.
Yeah. So there's some abuse going on there.
And in those cases, I won't operate on them.
Defer, yeah. So what about young girls? Because that's an important topic. I'm talking teenagers, not even in their 20s. How often should they have implants? Should they wait?
Putting aside people with like imbalance,
Not deformities, yeah.
Right.
No, I mean,
For aesthetic.
a young woman that says, I have small breasts. That's just my genetics. I would like an enhancement.
I think it would depend. I always go back to, it depends on how, one, have they finished puberty? Have they stabilized in growth? Have your breasts been the same size for a year to 2 years? Okay, because I don't want to operate on anybody whose breasts are still growing, outside of congenital problems. But I think, if you have a woman whose chest resembles a child and they have almost no breast mound at all, and they're through puberty and they're stable and nothing is growing and their breasts aren't growing, then I think that's a conversation to be had, because I think that's a real concern. Now, if a young girl comes to me who's, still in her teens and she has nice petite breasts that don't have a deformity, don't have an unusual shape, because even some women don't come in for breast size, but they come in for a shape problem. It's just like unusually, like aesthetically, like not pleasing.
Right.
Then I think they should wait. I think they should give it some time, be very thoughtful about it, make sure that they really want it, make sure they understand it. But that's not to say that there aren't ever indications, because there are some women who really don't grow proper breast mounds.
Right. Okay.
Hey, Roderick.
He's been sitting over
He's
there.
been patiently waiting. I know you got a couple questions. Jump in here.
Of course, I got questions, gentlemen. Okay, so, doctor, one question is, being a woman in, a male-dominated field, right?
It's easier to look at there.
Yeah,
than you
so
can see him.
it's a male-dominated field. So, are you treated any differently? Do you feel anything by being a woman surrounded by male doctors and being young at that?
Oof, this is a hard question, y'all, and I'll tell you because I think I am where I am in my career because I have navigated this well, perhaps. I give, males in my field due respect and I appreciate them. And I have a lot of male mentors who have treated me so well. Like, I can't even tell you how well they've treated me. But I think the most difficult relationship as a female surgeon is with other females, to be honest with you.
Oh, interesting.
The nurse, female doctor, female surgeon is a hard relationship to navigate. I think it's by nature. Women in the hospital, it's like the nurse culture versus the doctor culture. Nurses love male doctors. And I have had some nurses who I absolutely adore, and they're the most phenomenal human beings, and they absolutely love me too, and there's no weirdness. But I think there is a base biological clash of a woman having to take orders from another woman. And so I think I call it female on female crime.
Wow.
Is one of the most difficult relationships to navigate in medicine.
Yeah.
When did you learn that? As time went on?
In residency.
Yeah, especially as you mentioned, in traditionally more male-dominated branches of medicine, like surgery and plastic surgery. Right.
And not that I haven't had my own. I could tell you 20 stories right now about issues that I had with men navigating, medical school.
Yeah.
And kind of just like people born in different generations who had different approaches to things. And in my mind, I was like, I just have to understand when they grew up.
Yes.
It was very different from when I'm growing up. And so I'm also, because I had a different career before medical school, I'm 5 years older than my counterparts, right? And so I had a little bit more perspective. I'd actually worked with humans before.
You guys have that in common. You both went through, you were older than most of the people when you went through it.
Yeah, similar. But anyway, so
keep going.
That gives you.
So I think I had maybe
wisdom.
a little bit more experience and I had managed people before, on teams. And then I don't know. I think I saw other people perhaps struggle with it more, but I'm always a big believer, and I like to confront things with the person that the problem is. If there's an issue, I just like to get it over with that person and address it. If somebody touched me inappropriately, I don't mean weird stuff. I just mean I had old male surgeons who'd just do things that were it was just not appropriate, right? And I would just address it in the moment and just make it very firm that I was I'm here, I'm professional, I'm here to work, and I'm not here to do anything but work.
Yes.
And they would always respect that. And then I could go on to actually have an amazing working relationship with a man who had previously been inappropriate, but once he knew my boundaries, then a lot of times they would respect it. I had male residents, when I was a medical student and I was trying to get a job, I had them trying to take me home. And I would set boundaries and be very clear, not beat around the bush, and just say, I'm here to get a job. I'm here to work. I'm here to learn. And if you want to further this relationship in that capacity, I'm open, but I'm not interested in any of this other stuff.
The advances, yeah.
And you would be surprised how much even people with different standards of morals and ethics would then respect mine.
Well,
absolutely.
Setting firm boundaries is its own reward.
Absolutely. But there have been generations, as Lindsey mentioned, of males who were misogynistic, were crossing those boundaries daily without thinking twice about it, and the younger residents and interns, kind of well, that's the way it is, and not only with doctors, female doctors who had similar or even more training, but with nurses as well, because it spills over to the male doctor-nurse relationship that can cross lines in a very inappropriate way. I think we made a lot of advances by creating awareness, setting boundaries, what is appropriate, what is not appropriate.
Well, just the more you have females in the workforce and in the field, then people adapt and change.
Yes.
People have, it's the difference between being an all-male locker room to all of a sudden it's integrated, and people just have to adapt and change their behavior.
Yes. And we have more females graduating now from medical school, right? Almost in most fields, I would say. Certainly in mine, in internal medicine, there are more females. Yes. And then from there, jumping to be whatever of the 15 or 16 subspecialties after internal medicine, one of which is cardiology. So,
did you hear about the study recently that they looked I'm talking
me.
to a male doctor right now,
Tell me.
but I want to talk about this.
Yeah, go for it.
There was a study recently that looked at female versus male outcomes of patient care, and patients that were under the care of a female doctor had better outcomes overall than male doctors.
Yeah. Well, I would. Well, I mean, overall, with generalizing a bit,
It
females
is
are more
generalizing.
empathetic. They're more sympathetic. They're as long as they're conscientious, and they are also probably more capable of building that trust factor with patients that are more likely to follow
It is
short
a-
and long term their recommendations.
Right. It is a generalization, though, right?
It's a big
I think
generalization,
that was it was a study that I think was performed correctly, but at the same time, we're still talking about humans, and human
Yeah.
behavior differs wildly. I know just as many
Yes, absolutely.
good males and females.
No, of
versus
course.
poor
It's the
males and
person.
females.
It's the person.
Yes.
It's their own values, their own morality, their own ethics. There are factors that go into it. The mentors you've had and the example they set for you, and what you've incorporated as who you are and how you exercise your profession.
Roderick, you got any more for us?
I got a bunch, but I'm going to narrow it down to 2. So another question I have you ever done any surgery on any good friends or family
Oh, yeah.
members?
I have.
Is there a lot more pressure with that or anything?
The first time, yes, in a way, but then I've gotten to the point where I see a lot of my patients as family by the time I get them to the operating room. I'm so invested in their outcome, and I'm very lucky. I think I attract patients who have similar mindsets and goals as I do. I think that's just something that the universe does, is it just like draws people together. And I usually connect with my patients and just have such a special relationship with them that no matter who they are, I'm very committed to their result. So I always have that let's get this person the best possible outcome. But I have operated on some of my very best friends, and of course it brings something else into the picture. This necklace is actually, a lot of people comment on it, it's actually a cute rendition of boobs, but a good friend of mine that I operated on, that I did a mommy makeover on, she's one of my best friends in the world. She gave me this
was a
necklace.
gift.
And so this
Very
is
nice.
very special to me, because she's not only one of my very best friends in the world, but I was also able to do her mommy makeover for her. And she kind of exudes everything I believe in, which is she works out, she eats healthy,
Everything right.
but her babies changed her, and she just wanted to feel
Right.
better about herself.
Good news, I'm not a urologist.
You don't have to operate on all your
No, he's
male
talking about the necklace.
Oh, that too.
That's funny.
But also, you don't have to see all of
I
your
don't.
friends.
I do have hearts and all kinds of keychains and
I bet.
T-shirts and sometimes hearts. Valentine's hearts from patients.
Oh,
In the
cute.
shape of a heart.
Cute.
It's cute.
And you
In
said-
my heart.
Sweet.
See? In our
Yes.
permanent prop here of the cardiac.
I
thing.
love it.
So you said you had one more question, Roderick?
Yes. Last question is, being a young doctor, and I'll give an example. Going on taking a flight and seeing that the pilot looks really young. For some people, they feel more patients or customers or people flying on a plane. They feel more comfortable with someone looking more seasoned.
Mm-hmm.
So, do you get any type of comments or questions or worry or concern about you being young doing surgery?
Oh, yeah. I mean, I've been through a lot of that. I'm not as young as people think that I am. So
Well, see, that's what I would say. I would say, actually, I'm so good that I'm actually 97.
yeah, exactly.
Blue zone.
But it is something that we call the gray hair effect. And that's that, if your doctor has gray hair, you're like, they must have
Yes.
more wisdom. They must have more. I think, obviously, I've dealt with this from the standpoint of I've had patients, I introduce myself as doctor, I will wear a white coat. This is more in training and residency, right? And I would talk to them, and I would see them every day in the hospital and rounds. And at some point in time, they would pipe up and call me nurse, or they would say, well, I haven't seen my doctor all week. And I'm like,
Hello.
that's
Wow.
fine. But, I honestly, I'm 37 years old, and a lot of my patients think that I'm 22.
Yeah.
And so I
You
have
look
to,
really young.
thank you. I have to remind them,
That's a
I'm
compliment.
good skincare. and, treat your body well.
Yes.
I am old enough to, probably have done a lot of things in my life, but I've dedicated it mostly to education.
But one of the
and-
things that comes across from speaking with you and listening to you is you have a very positive outlook to life. And when you have that, and I assume you have a great relationship with your husband, that positivity translates into staying younger. And
I think
we
so.
can go into the neurochemistry of that, of the oxytocin you're getting from your patients, like the one that gave you that beautiful gift, the oxytocin you get from other patients, from your colleagues, and from your husband, that result in liberating and secreting more serotonin and clearly dopamine, and preventing inflammation, increasing autophagy,
Yes. All
getting
my
rid
favorite words.
of oxygen radicals. And then if you feed that with great nutrition and then great relationships with friends,
Yes.
there may be just a couple, doesn't have to
Community
be
is so important.
community. We've talked about these topics at one time or another, but they are part of what we should transmit to telling patients. My job
Yes.
is to keep you healthy,
Yes.
not treat you only when you're sick,
right.
but hopefully provide great
Keep you from getting sick.
recommendations and keep you healthy.
So
right?
that goes to my final question, then we can wrap up. And I want you to give your information so all our listeners can
yes.
go to you for their, because you're obviously now the official plastic surgeon of the Leverage Podcast. How did you get so interested and invested, just like Dr. Suave here is not unique, but rare amongst cardiologists, that he cares about nutrition almost as much as just trying to do procedures. How did you make that transition to where you are so, obviously that's why you and Danielle got close, where
Yes.
nutrition and health, tell us a little bit about that journey, because it's pretty rare amongst doctors.
Right. So I think it first started for me when I first gained a few pounds from the Starbucks. And so I realized I needed to think about it. And I started a little bit of my own, just like self-discovery. I also, in college, had a point my junior year where very abruptly I started having GI issues from food, and just through my own investigation, because
Right.
when I would go to the GI doctor, they just kind of looked at standard things. They're like, well, we don't really see anything, like you're
Right.
fine. But I knew that every time that I ate food, I was in severe pain. Almost every food, or even black coffee, I was in really bad pain. And so I went on this whole discovery of food and trying to figure out. Many, many, many years later, I realized that I don't have an allergy to a specific food. I have a reaction to things that have a lot of chemicals in them.
Right.
And so I am very careful about the types of food that I bring into my body, just from my own functional standpoint, so that I don't have pain when I eat.
Right.
And when I drink. If I have a cup of Folgers coffee right now, I will be ruined. I'll be wrecked because
That-
there's
the
so many
chemicals in there.
chemicals
Right.
in it. And even some healthy food. Like, a lot of people don't know that a lot of the almonds in the US come from a basin in California that's full of pesticides.
Right.
And I've always known that if I ate almonds within 2 minutes, I was like in severe pain, but I didn't have an allergy.
Right.
Um,
you
It
have
was
food
the
int-
pesticide.
Yes. But what she's describing is a whole history of food intolerances. And she was developing inflammation, gut inflammation, and
Yes.
dysbiosis with the wrong
Yes.
bacteria growing. And so she's discovered it by elimination over time.
Right. And
Did you ever do
I-
food intolerance testing?
I honestly didn't, because by time I probably had like the means and the capacity to do this.
Right.
I had already done all my own like little elimination diet
Right.
to figure out what I could tolerate.
Yeah.
And the only common thing was like pesticides. So I realized I can't eat bananas,
Processed foods.
avocados, apples that are not organic.
Right.
But I can eat organic ones, and it's
And
perfect.
you're fine. Yeah.
I can eat pasta, dairy abroad when I'm traveling in other countries.
Oh
Over
my
years.
God, it's so true. In Greece,
Yeah.
I eat bread like it's
Everything.
going out of
Yeah,
style.
but
Yes.
it's made differently.
Yeah, right.
Yes.
Of course.
Yes.
They have different standards for pasteurization. They
Yeah.
have different standards for genetic modification. And so I'm so happy when I travel, because I get to eat whatever I want.
Right.
And I'm just so happy.
And here you have to be selective.
Here, I have
yes.
to be so incredibly selective
Yeah.
in order to but it had its benefit, because if I never had that pain, if I was just somebody who could eat a cheeseburger, not gain a pound, and also feel comfortable,
Yes.
then I wouldn't have gone on this pursuit.
Right.
Also, seeing diabetes in my dad's side of the family made me
It's scary.
thoughtful about the future.
Yeah.
And I just thought, how can I optimize my own diet and learn about this? And then of course I pursued, my master's in public health. and then learned all about how social constructs can affect health,
Right.
about food companies and like politics and, where you're born, where you live, who your parents are, what happens in your home. And so my journey into like being into like longevity and diet and nutrition
Right.
all just came from me troubleshooting my own issues.
Yes, and you learn from there, and consequently, you have better health, and you can then pass that on to your patients.
And something I think that is lost that people need to understand is people think you can exercise to make up for what you eat.
You can't.
And you can never outrun
Run
a bad diet. Ever.
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 That's right.
It
Fully
sounds like you've been
agree.
listening to the podcast.
Yes. No, we agree. We agree. And, it is important to also understand the genetic pool from which you come from. And I've spoken about that because how your ancestors ate 10,000 years ago, 5,000 years ago, before there were chemicals in the food industry, and other factors like those that were from an agricultural society versus those that were hunter-gatherers, those that were not exposed to all kinds of lard and sugars every day and red meats versus those that were eating crickets and fruits and few vegetables and an occasional fish and rarely a rabbit. We cannot go and eat the standard American diet full of fast food. We did a whole segment on fast food, did we not?
Yep.
And so for those of you, go back and see it because the numbers are atrocious, and it goes to explain what was mentioned at the beginning
You're
of
talking
this
about how
conversation.
much, I think on that episode you were talking about how much fast food is on like TikTok and
Yes.
Instagram.
Yeah, it's
That
more
blew
than
my
a
mind
billion
because I didn't know that.
advertisements. Yeah, it's horrific.
I had no idea
Yes.
until I heard that.
And we went through the prices and how much it all costs. And so I always have, and I repeat this often and often with some of the celebrities that advertise currently during NFL games or during NBA games or college football.
Sprite.
For fast food establishments and things like Taco Bell. There goes our sponsorship. By the way. And I go, really, dude? You're advertising for them? I don't think that's appropriate.
No, it's
With the knowledge we have
horrible
now.
example.
Yeah.
But it's where the money is.
Yeah, but that is wrong still. You're in a profession that people pay a lot of money for their plastic surgery procedures, but you cannot ever
Never.
break or
Never.
ignore ethics and morality. Cannot.
100%.
Yeah.
And that, bringing it back to plastic surgery, is the difference between, in my mind, a good plastic surgeon or somebody parading as a plastic surgeon.
Yes.
Because there are internal medicine doctors
Yes,
who
doing
have
stuff.
plastic surgery practices
Yeah.
out there.
Not
but
me.
it is
As you can see, not me.
plastic
We'll get you in there.
surgery. Plastic surgery is not a menu like a fast food restaurant.
No.
You don't get to show up and pick off the
That's
menu
great.
what you want.
I
There's
want this.
there's properly indicated procedures.
Yes.
And then I can tell you, I say no probably as much as I say yes.
Yeah. Well, then you're in the safe zone of being ethical because that's the guideline that we must all have. We have to answer to ourselves. You have to be accountable.
So how can our listeners who
Yes.
how do they contact you? Please let us know. Please tell exactly the best way to get an appointment with you and see if there is something that you can do to help them.
Absolutely. So my practice is in Preston Center. Our phone number, if you want to, I love it. It's an old Dallas phone number, which is great. It's 214-363-4444.
Oh, that's a great number.
When you call that number, you will talk to one of two of the most wonderful women ever. Our practice is like a family. We treat each other like family. We treat our patients like family. We have patients who just stop in off the street when they're driving by to come and say hi because we just have a great relationship with them. And it's just, we just love being around each other. But you can also follow me on TikTok and Instagram and my website. My TikTok is Dr. Lindsey Plastic Surgery. My website is highlandparkplasticsurgeon.com. And if you go to any one of those, then you'll find links to everything else. I have, a
Perfect.
YouTube channel. I have, I have everything.
All of those.
Wonderful.
Beautiful. So, Roderick, any other comments? I would like to set up another follow-up podcast to discuss some of the topics that we touched on, which is about the U.S. healthcare system, public health, how will we deal with the next pandemic, how will we deal with insurance companies that at times don't want to pay for vital things, how will we evolve with Medicare.
You need to get my husband in for that one
Yes.
because he
sees that.
He deals, as do you, I'm
In
sure.
cardiology, same thing.
He ends up on a phone. People don't understand
To
this.
insurance
Like
companies.
he sees somebody and he says, you have a real problem that needs to be fixed.
Right.
And then he ends up being put on a phone call with a pediatrician who's evaluating him to see if he's properly indicated a hand surgery.
Yes.
And he's like, you don't even have the training to
Right.
understand.
To have my
and,
disc-
and they say, well, haven't you tried NSAIDs?
Yes.
And he's like,
I get that with indications for stress tests, for nuclear stress tests,
Exactly.
for cardiac MRIs,
right.
for PET scanning, for
And you're
things
not
like
talking to a cardiologist.
No, you're
who
talking
knows
to a
what they're
nurse
talking-
sometimes.
Yes. Yes.
that. A nurse reviewer.
To determine whether or not you can properly care for your patient.
Yeah, it's
It's
an
sad.
issue.
Well,
So-
we're looking forward to talking to your husband because he definitely.
Yeah,
is-
we'll have them both over, and then we can have a roundtable on these different important issues that are of concern for many people.
Yes.
Definitely. So Davio, take it away.
Thank you so much for joining us, everybody.
Absolutely.
This has been the Leverage Podcast. I'm your host, Davio Venturis. We've been joined, as always, by Dr. Federico Messi, Dr. Suave to the rest of you. And Lindsey, thank you so much.
Absolutely.
And I'm going to butcher the last name again.
Tavakolian.
Tavakolian.
Yeah.
You have been an absolute delight, and you are now the official plastic surgeon of
What
the
an
Leverage
honor.
Podcast.
Thank you.